All right, well, welcome everyone. We're going to go ahead and get started with today's lecture. So my name is Iman Khwaja Reddick. We are pleased that you could all join us for this week's lecture in Volume 10 of our No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of our main goals of No Neuropsychology is to provide free, high-quality didactic content to our audiences. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website and through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Rosalia Costello for today's lecture titled The Pediatric Neuropsychologist's Role in Epilepsy Surgery, Clinical Care and Patient Advocacy. Dr. Costello is a pediatric neuropsychologist and assistant professor at UT Austin Dell Children's Hospital in Austin, Texas. She specializes in comprehensive neuropsychological evaluations for children, adolescents, and young adults with drug-resistant epilepsy who may be candidates for neurosurgery, as well as conducts brief assessments and provides multidisciplinary care for youth with spina bifida. Dr. Costello received her bachelor's degree in psychology from Loyola University in Chicago, where she minored in Spanish language, Italian language, and communications, and completed a study abroad program in Rome, Italy. She completed her master's degree and doctorate in clinical psychology with a specialization in neuropsychology from Adler University. Dr. Costello completed a pre-doctoral internship in pediatric neuropsychology at the University of Minnesota Medical Center. And then she completed a 2-year postdoctoral fellowship at Baylor College of Medicine and Texas Children's Hospital. Dr. Costello's research and clinical work routinely focuses on health disparities, culturally informed care, and bilingual brain development in pediatric medical populations. She has presented locally, nationally, and internationally, and is active in several neuropsychology organizations with the aim of fostering equity and inclusion for patients, students, and providers alike. Dr. Costello also serves on the board of directors for the Hispanic Neuropsychology Society. With that, I am so excited to turn it over to my incredible colleague and dear friend, Dr. Costello.
Thank you for that introduction. Let me share my screen here. How does that look?
That looks great.
Okay. All right, let's get started then. So my hope for today is to outline the role of a neuropsychologist in an epilepsy team. My experiences come from my work in academic medicine, where I have a lot of opportunity for interdisciplinary care and where I work with a very diverse patient population, conducting evaluations in both English and Spanish. As I walk you through each step of the process of the road to potential epilepsy surgery, I hope also to elucidate the multiple areas of expertise that we cultivate throughout our training as neuropsychologists that make us an integral part of these medical teams. I also want to prime everyone to think not just about the patients we see in this setting or in any daily neuropsychology practice, really, but the patients we're potentially missing due to health disparities or barriers to care. And then finally, in the spirit of the beautifully written chapter, The Role of Neuropsychologists in Social Justice Advocacy by Dr. Mireya Diaz-Santos and Dr. Kendra Anderson and colleagues in this book, edited by Dr. Farzin Irani, I want to encourage everyone to consider how they can move from passively receiving information from a talk like today's and from these didactics in general, more transmissional learning, to using that information to creatively transform or inform their practice in some way that best serves their patients. So in case anybody's not familiar, I want to start with a definition of socially responsible neuropsychology, or SRN. So Doctora Paula Suarez and colleagues coined the term socially responsible neuropsychology in their 2016 article to emphasize the need to move from an individually based awareness of health disparities or certain barriers or social determinants that keep all patients from getting equal care, to the need for us as individuals to be aware of and to actively work against health disparities, to a more systemic and organizational response to health disparities. So in other words, for every reason that we as neuropsychologists consider neuropsychology valuable, we need to be actively working to break down the barriers that keep certain patients and certain groups of patients from accessing that value. So socially responsible neuropsychology challenges our field to engage in individual and organizational practices that benefit all patients in an equitable manner, regardless of their race, ethnicity, sex, language, or sexual orientation. And each person, organization, and institution has an inherent responsibility to act in a manner that promotes the positive growth of and protects the rights of every individual. So I want everybody to be thinking about this concept of socially responsible neuropsychology throughout the presentation as we think about what it means to engage in advocacy as neuropsychologists. Talking about seizure and epilepsy classifications and etiologies and syndromes is certainly beyond the scope of today's talk, but I will very quickly review some basics to give a sense of the core knowledge a neuropsychologist in this setting needs to have. So a seizure is a transient occurrence of symptoms and or signs due to abnormal, excessive, or synchronous neuronal activity in the brain per the ILAE. When we're talking about where the seizure starts in the brain or seizure onset, we have seizures that begin more focally or localized to a specific area versus seizures that are generalized in nature that immediately or pretty quickly involve the whole brain. And seizures can also start focally and then generalize. For reference, here's the ILAE classification of seizure types that further breaks down differences in focal versus generalized versus unknown onset. Someone who has experienced a seizure, or in some situations, even multiple seizures, did not necessarily have epilepsy. So how exactly do we define that? So epilepsy is at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure and a higher probability of further seizure. So provoked referring to some sort of agitating factor that caused that seizure. And in some cases, we can clearly identify and potentially even correct that factor. And epilepsy affects millions of children worldwide. And then where does epilepsy come from, or how do we discuss epilepsy etiologies? So the current ILAE classifications for epilepsy etiologies are in the headers here. And knowing the etiology can inform the treatment course of epilepsy. So we may have structural etiologies like malformations of cortical development or vascular malformations, or various chromosomal or genetic abnormalities, for example. Metabolic etiologies like a cerebral folate deficiency or mitochondrial disorder, immune etiologies like Rasmussen syndrome, infectious etiologies like bacterial meningitis or HIV, or unknown etiologies. And while we'll focus more on the intensive workup that patients with refractory or drug-resistant epilepsy undergo, I'll mention that after the first paroxysmal event or known seizure, patients usually undergo a neuroexam, an interview with their primary care or neurology provider, trying to determine whether there was a provoking factor that could be corrected or whether there is a clear etiology for the seizure. So that workup will also typically include a routine EEG, usually done in office and not always capturing seizures due to its abbreviated nature. And in many cases, an MRI to check for any structural abnormalities that might impact the treatment course. The first line of treatment for a new onset seizure or for epilepsy will be anti-seizure medications. And those medications are chosen based on the information that the provider has so far about the seizure type. So once 2 frontline anti-seizure medications or ASMs are failed, the chance for seizure freedom with additional medications can be as low as 4%. So the majority of patients, about 2/3, will respond well to medications and attain good seizure control. And then epilepsy is considered refractory or drug resistant if the patient is not seizure-free after 2 adequate trials of ASMs, meaning appropriate medications were chosen for that patient and for their seizure type, and they were trialed for long enough to be considered an adequate attempt. ASMs have their own side effects that neuropsychologists need to be aware of. So some have reputations for certain side effects like topiramate or Topamax being referred to as Stupamax or Dopamax because of the feeling of cognitive sluggishness and fog that is commonly reported. And in general, patients tend to report fatigue and slower processing, even though that might not always be captured on standardized testing. For patients who don't respond well to initial trials of medication or who are determined to be drug resistant, we'll then have a more comprehensive workup. So not all patients will progress through all 3 of these phases. So a quick overview of these phases before we dive into each one. Within phase 1, in some cases, a patient might be trialed on a medication that actually makes their seizures worse. So some ASMs exacerbate particular seizure types. And so at that point, the team needs more data about what kinds of seizures or what kinds of epilepsy that patient has in order to more selectively choose medications to treat them. So at a level 4 epilepsy center like Dell Children's, where I work, patients usually come to our epilepsy monitoring unit or EMU for an inpatient stay to receive further workup like video EEG. So remember, we've likely done a routine EEG outpatient that may or may not have captured seizures, but on the EMU, we'll have video EEG, MRI if the patient has not yet had one already, SPECT for some patients, and for some patients, a comprehensive neuropsychological evaluation that at that point might be considered a pre-surgical evaluation or might just be considered a baseline. For patients where progression to surgery is more strongly suspected, usually the team will order additional testing like fMRI, MEG, WADA, TMS, or PET to further localize seizures, and we'll discuss neuropsych's involvement there. Genetic testing is also something that we've been pursuing more consistently here at Dell. It seems to vary a bit in terms of where in the sequence it may or may not be ordered, like phase 1 or phase 2. If the team is still considering some sort of surgical management in a refractory or drug-resistant patient, the patient might then progress to phase 2. So during phase 2, we'll see more invasive monitoring like SEEG and often language mapping using SEEG. And then in phase 3, we proceed to our surgical interventions like resection, ablation, or neuromodulation. Okay, so let's talk more about phase 1. So while on the epilepsy monitoring unit or the EMU, the patient and family are cared for by a whole host of specialists, including neurology, epilepsy-trained nurses, EEG techs, a neuroradiologist, the neurosurgeon, and either while on the EMU or inpatient or in the outpatient setting, but alongside the EMU stay, neuropsychology. So at this point, what I'm going to refer to as phase 1 to 1.5, what is neuropsychology's role? Well, per the ILAE, the neuropsychologist's role is to 1, establish a baseline against which change can be measured following surgery. 2, provide a collaborative contribution to seizure characterization, lateralization, and localization. 3, provide evidence-based predictions of cognitive risk associated with surgery. And 4, provide the evidence base for preoperative counseling, including patient expectations of surgery. So the baseline or pre-surgical neuropsychological evaluation is one important piece of the puzzle during phase 1 that helps the epilepsy teen hone in on the seizure onset zone or the epilepsy classification or the specific syndrome. So I always explain to parents that while other members of their epilepsy team are gathering their data or their pieces of the puzzle by doing things like taking pictures of the brain with MRI or measuring electrical activity in the brain with EEG. As the neuropsychologist, my job is to look at how the brain is functioning. So compared to other kids that child's same age, in terms of thinking and reasoning skills, and then to bring my knowledge of the brain, like functional neuroanatomy and neuroplasticity, and behavior, like cognitive skills, so bringing that brain and behavior together to help figure out not only where seizures are coming from, but how epilepsy is potentially impacting their child in day-to-day life. From there, I can help the family and the epilepsy team set some expectations about potential risks of surgery while also problem-solving ways to support their child in any areas of weakness. In pediatrics in particular, the neuropsychologist needs to be able to do a lot more than look at standard scores and describe strengths and weaknesses. So the neuropsychologist's role is to be an expert in neurodevelopment and to understand neuroplasticity. So beyond what would be expected for a given age, how might the brain flex or adapt to accommodate for the injury of seizures? So let's talk a bit about language development and organization to kind of illustrate what I mean by this. So we know that the language dominant hemisphere is usually established in childhood, typically by the age of 5 or so. The majority of humans are left hemisphere dominant for language, but it's really thought that most people have potential for language and possibly even existing language networks in both hemispheres until the left hemisphere establishes itself as the dominant one through synaptic pruning, et cetera. However, if there's a reason early on for the left side of the brain to not become the language dominant hemisphere, because the brain is still malleable or plastic, it might be more likely to recruit those once secondary language networks in the right hemisphere and ultimately establish what we would then consider atypical language organization. So it makes sense then that patients who have seizure onset at a young age are more likely to have atypical language organization, which could be right hemisphere dominance or could be bilateral representation of language. This is why, particularly when the epileptogenic focus or the seizure onset zone is expected to be anywhere near language, this comprehensive workup that I'm describing is so important. I also want to reference the crowding hypothesis here, which is tricky in peds. So when the brain reorganizes in order to spare language, there's also the issue of ending up with limited real estate. So the crowding hypothesis suggests that if language networks need to take over what was initially destined to be cortical real estate for visual spatial skills might be depressed as that taken over real estate has to come at a cost. Now we potentially have different modes of information processing, competing for space, ultimately resulting in less function or less efficient functioning in theory. But a lot of that theory originally came from adult models, and some pediatric studies have found that patients with atypical language dominance actually have comparable scores on language measures. Others have found depressed functioning in both verbal and nonverbal skills, and some studies have found no association between atypical language and verbal versus nonverbal abilities. So this 2019 study referenced here suggested that while their atypical language group performed comparably to their typical language group on vocabulary knowledge and verbal abstract reasoning, aka the VCI on the WISC, the typical language group performed significantly better on a naming task, particularly in a group of patients with temporal lobe seizures. And they also performed better on visual spatial testing, potentially offering support for the crowding hypothesis in peds. So in other words, cognitive development in pediatric is really a moving target, and the findings of our evaluations can be complex ones to communicate. Further complicating or maybe enriching interpretation of our findings are cultural contextual factors. So children don't operate in a void, and their performance on our tests are influenced by cultural factors like the languages they speak, the educational opportunities they've had, socioeconomic factors and potential adverse childhood experiences, and psychological factors like mood and resilience or grit. Some of these factors impact neurodevelopment, and again, it is our responsibility to be familiar with that literature. So I discussed the ability for the brain to recruit secondary language networks because of its malleability. This is also something we see in bilingualism, where it seems that exposure, especially intensive exposure or immersion to a second language, especially early on, results in or can result in atypical or bilateral representation of language networks. So some have even hypothesized that bilingualism might therefore serve as a protective factor or resiliency factor in patients who develop epilepsy. With a solid understanding of these cultural and systemic factors, I would argue that the piece we add to the puzzle is so much more meaningful, and we also avoid doing harm by misdiagnosing or misrepresenting the patient's abilities. Neuropsychology is also involved in what I said I would refer to as phase 1.5. So with that knowledge of neurodevelopment and the cultural factors that impact it, neuropsychology is also involved in this quest, not just to locate, but to protect language and motor skills and memory skills as much as possible. So if we're continuing on this road to possible epilepsy surgery, even if we've really consistently localized the epileptogenic zone with MRI, with SPECT, with EEG, with neuropsych testing, these phase 1 things that I've mentioned, we don't want to cure the patient of their seizures by disabling them of other functions, right? So in this phase, we more carefully map functional brain tissue in order to avoid damaging it. So the goal in a surgical intervention, like a resection or an ablation, will always be to remove as much of the epileptogenic focus as possible with as little functional damage to the patient as possible. So some of these techniques can help with mapping motor, language, and memory skills. So this usually happens following, at our institution, following discharge from the EMU, hence the kind of 1.5 phase. Neuropsych involvement varies from hospital to hospital in these different modalities, but here at Dell, we're most consistently involved in fMRI and WADA testing. I know there's an upcoming No Neuropsychology didactic on language mapping. I'll speak to this very briefly here and just what my involvement looks like. So in fMRI, depending on the particular patients, neuropsychology typically does baseline training where we teach the patients to exactly the paradigms we'll be using to map out areas of eloquent cortex. We want the patients to know what to expect when they're coming into the MRI machine. So some of the tasks might be naming tasks, verbal fluency tasks, auditory decision-making tasks, and motor tasks. So the patient completes these in the scanner, and the fMRI tracks blood flow. So as neuropsychologists, we're typically present in the suite to guide the patient through each of the tasks that we've already practiced a couple of times, and to monitor the initial images that look something like this before they're officially read by neuroradiology to see whether activation looks to be in the expected areas. So the areas that start to brighten up on an fMRI scan are the areas of the brain currently receiving the most blood flow and therefore thought to be active during that particular task, helping us localize or lateralize those skills. In WADA, which is used a lot less since fMRI is less invasive and has become more popular, we also conduct baseline testing of naming, receptive language, reading, and visual and verbal memory tasks with the patient, usually the day prior to the actual test. One, so that they'll be prepared for what takes place during testing, but two, to establish a solid baseline of what the patient can do with both brain hemispheres. During the WADA itself, the patient is hooked up to EEG, an opening is made in the femoral artery in the groin area, a catheter is inserted and advances up through the vascular system to the internal carotid artery, and a dye is injected so the team can check on angiogram and confirm that what is being injected is staying in one hemisphere of the brain and that there's no significant cross-flow to the other side. The neuropsychologist then takes a grip strength to measure baseline strength. And when everyone's ready, a short-acting anesthetic, historically sodium amybarbital, but this has been more difficult to come by, is injected into one hemisphere, usually the one that's suspected to be the language-dominant hemisphere first. And the patient is holding their arms up and their contralateral arm will drop when they're no longer able to hold it up. And then the epileptologist confirms on EEG that that hemisphere has been anesthetized. So neuropsychology then does their testing. Once with EEG monitoring and grip strength monitoring, that hemisphere seems to have come back to baseline or back online. We do free recall and we do recognition. And then that process is repeated in the second hemisphere. So in this way, we can see what the awake hemisphere is able to do without any assistance from the other hemisphere. So while our WADAs are few and far between, we most often are doing them on patients that are older, that are higher functioning. The patient really needs to be still and able to actively engage in the testing that lasts only a few minutes and can't be repeated. And patients where there's not been total concordance amongst the different data pieces we've gathered so far regarding which is the language dominant hemisphere. To conclude phases 1 to 1.5 and decide on next steps, the team of all those specialists I outlined a few slides back meets to review each piece of the workup. So in addition to describing the patient's neuropsychological profile and contextualizing those findings as related to their epilepsy type and their neurodevelopment, I try to cover each of these bullets with each patient. So do I think my results are considered valid based on performance validity, whether the patient had any seizures during testing, or was there anything else that got in the way of their best performance? Is their current medication regimen thought to be impacting the results? I mentioned some of the known side effects earlier, so need to be aware of those. I will comment on whether I think results are lateralizing or localizing, and whether that lateralization or localization is concordant with the workup thus far. What are the potential risks of the surgical intervention proposed, like cognitive risks or mood-related risks? And relatedly, are there any additional recommendations for the medical team? Like something we'll talk about is bilingual language mapping. So as we start to talk a little more about advocacy in each phase of this potentially pre-surgical workup, I want to emphasize that advocacy doesn't always mean, marching on the steps of the Capitol building or calling representatives, advocating for policy change. Those are great things, but many neuropsychologists engage in patient and family advocacy on a daily basis in ways both big and small, maybe even without knowing it. So during phase 1 of workup in a patient with epilepsy, advocacy can take place on behalf of the patient with the medical team. So because I, as a neuropsychologist, gather such rich information about language development and bilingual language history, both through interview and standardized testing, I'm often advocating for patients that need bilingual language mapping, as opposed to mapping only in English, for example. I also get some rich insight into the overall psychological and socioeconomic makeup of the family, and can sometimes serve as a liaison when patients are being perceived or families are being perceived as not following through with recommendations, when really they might need some more education, psychoeducation, to get their buy-in. And this is more with outside referrals, but I've also had to advocate for bilingual patients, pediatric or adolescent patients, to not have to serve as interpreters for their medical provider and parents in the context of their medical visits. Another important area of expertise for neuropsychologists is that of school-related laws and available accommodations from state to state. So ideally, our written reports should serve as advocacy tools for families as they seek appropriate supports and accommodations for their children in the school setting. So I often have families explain to me what can be the challenge of having a child with what might be a more invisible disability. So if seizures are relatively well controlled, maybe their teachers have never even seen one of their seizures, but epilepsy has still impacted the child's cognitive development or availability to engage in the standard academic curriculum or access that standard academic curriculum. It might not be immediately obvious to educators as compared to a student with more global intellectual impairment or with a more physically obvious disability, what services that child needs. So I try to help by both outlining those ideal accommodations in the report, but also by psychoeducating the family about the best ways they can communicate their child's areas of weakness and advocate for services in the school setting. So that's something we might talk about in the feedback, for example. Other areas of advocacy in this phase might be advocating for flexibility in typical hospital or departmental standards to improve patient access to our services. I'll talk more about that in a few slides, or advocating on behalf of patients on that larger, more community-based level. So now we enter phase 2 of the workup. So at this point, the team of epilepsy providers has met, has reviewed the results of all the testing mentioned, and is starting to hone in on that epileptogenic zone that is potentially the surgical target. particularly when eloquent cortex is involved or there's any concern that surgery might in some way harm the patient or harm them more than help them, we might move on to phase 2, a more invasive workup with the aim of mapping the seizure focus even more specifically so that surgery can be as targeted as possible, or so that the team can decide on alternative treatments like diet therapies, like the ketogenic diet, or certain neuromodulation or palliative devices. So like I said, as compared to the phase 1 and 1.5 mapping, phase 2 is more invasive. So in general, these days at our institution, we're much more likely to see SEEG over strips and grids or depth electrodes. So SEEG allows for 3D placement of tiny electrodes in various brain regions by the neurosurgeon. The electrodes are like thin, floppy wires and are very specifically placed in order to be able to pinpoint seizure onset zone and areas of eloquent cortex. And the patient is then monitored on the EMU after the placement. So neuropsych is usually involved in language mapping during electrical stimulation with SEEG. So the epileptologist can choose specific electrodes to provide stimulation, at what strength and for how long, while the neuropsychologist performs tests evaluating various cognitive functions to see whether the patient can still complete that task or engage in that cognitive function, which we have established they were able to complete that easily at baseline. Can they still do that while that area is being stimulated? Currently, we'll just mention the only pediatric patients who undergo strips or grids are usually those who are very young, whose thinner skulls can't support the bolts needed for SEEG electrodes. Strips and grids in general have higher morbidity with more risk of bleeding or infection. So how might neuropsychologists be serving as advocates during this phase? I mentioned earlier as one example, how bilingual patients are more likely to have atypical language organization. So even further, there are a lot of factors that go into how much those 2 or more languages are likely to overlap or share real estate in the brain, like whether those languages were learned simultaneously or sequentially, whether they were learned early or later in life, how much immersion the patient has had in each language, and whether the languages are similar orthographically or not. So in our testing, it's critical to determine not only the functionality of each language, but to consider the cultural and family value of a heritage language and how likely what the team might be considering a secondary or a non-dominant language, how likely is it to be harmed if the patient isn't thoroughly mapped in both. It's not unheard of to have a patient be assumed to be good enough or proficient enough in English to undergo their entire workup in English. Even if this is the case, if the patient is English dominant, or that's the language they use the most, we have to ask ourselves, are we properly counseling families on the risks of neurosurgery if we aren't examining those values and expectations about that secondary language or that heritage language? As a pediatric person, I have a lot of patients who are bilingual that may very well be English dominant, but that use their second language, in my case, in my institution, in my work, often Spanish, to communicate with their parents or with the elders in their family. And so we can think about the implications of losing that ability. Okay, moving on to phase 3. If a patient does arrive at phase 3, there are a wide range of potential surgical interventions, some of which are likely to be curative in nature, and others that are expected to be palliative. So I'm going to click through some of these very quickly. So we have lobectomy, which would be resecting part or all of an affected lobe, anterior temporal lobectomy being the most common. Hemispherectomy and hemispherotomy. So that could be removing the frontal, parietal, temporal, and occipital lobes on one side of the brain, on the affected side of the brain. It could be removing portions of that hemisphere and then disconnecting the remaining tissue. Lesionectomy, people with a well-defined structural abnormality like a tumor or a vascular malformation could be good candidates for lesionectomy. So that would be removing the lesion and the surrounding brain tissue. Or laser ablation surgery, or LIT. So in LIT, MRI is used to map out the surgery. Laser is delivered with pinpoint accuracy to eliminate the seizure focus. It's more minimally invasive as the skull doesn't need to be opened. It's typically for smaller lesions, for example, for mesial temporal sclerosis in temporal lobe epilepsy. And then in phase 3, we also have the option of more palliative treatments and our neuromodulators. So sometimes some of these surgeries are considered palliative because they're not expected to be a cure for the seizures, but they might alleviate some of the more severe and dangerous seizures, or they might overall reduce the seizure burden for that patient. So in corpus callosotomy, usually for patients with severe generalized epilepsy who experience drop attacks and falls with the hopes of eliminating that type of seizure. VNS is a type of neuromodulation used to treat refractory focal seizures. So VNS sends regular mild pulses of electrical stimulation to the brain via the vagus nerve. These neuromodulatory devices are usually used in conjunction with ASM. So DBS is another type of neuromodulation therapy, typically used with ASMs as well, also considered palliative, but aims to reduce seizure frequency. And DBS delivers stimulation on a preset cycle and can also capture and report information about electrical activity in the brain. RNS is similar to a pacemaker for the heart. So the device is planted in the skull, tiny wires or leads are placed cortically where seizure activity is thought to be originating. And RNS is meant to monitor, detect, and respond. So as it's monitoring, if it detects something unusual, it responds by sending a burst of stimulation, with the hope being to stop the seizure before it starts or to keep it from spreading or generalizing. So pediatric epilepsy surgery can be curative, but even if it's only planned to be palliative, it could result in overall greater quality of life, especially in those patients who had good concordance among all of those data points we investigated in phases 1 and 2, especially when there's a clear target for surgery and surgery is done early in life or early in the course of the epilepsy. So why then are some patients who are good candidates for surgery never referred for surgery, or why did they come to us so late in the course of their epilepsy, or why do they ultimately not follow through with surgical recommendations? It's probably pretty obvious at this point that the surgical workup is incredibly involved. For children in particular, the family and caregiver burden is a heavy one. There are a lot of appointments that could include taking time off work that may or may not be paid, traveling and related expenses on hotel rooms or gas or food, as well as expenses for childcare for other children in the family. So what do we know about who is most likely to get surgery? Some of the factors found in this recent review by Winterhalter and colleagues: children whose parents are employed and who have higher incomes and who have college or higher level education with private insurance. So the family's most likely to undergo neurosurgery. In that review, they did not find any studies evaluating cultural factors like religious values related to surgery, whether or not that's acceptable, psychological factors like trust or mistrust of medical systems and providers. So we know that there are plenty of documented historical events in which medical research has taken advantage of or intentionally harmed people of color in the name of research, resulting in very valid mistrust of medical systems and medical providers. And proceeding with an intervention as invasive as brain surgery certainly requires a lot of trust that what is being recommended is truly the best course of action. Interestingly, language was not a barrier to care at sites that had services and resources available in the parent's primary language. So it's also part of our role as neuropsychologists and providers to continuously evaluate our own practice. And again, to ask, who are we reaching and who are we failing to reach? How can we provide equitable access through psychoeducation, provision of language services, building trust with our patients and their communities, and identifying hospital resources that might be available to us? So part of socially responsible neuropsychology or advocacy with this population is in continuing education and continuing our own journeys of cultural humility. So even someone as a provider who's not bilingual, but who might be the best the person best suited in the area to evaluate a bilingual child, how can you utilize available resources like continuing education and consultation opportunities offered through the Hispanic Neuropsychological Society, for example, or available literature about working with interpreters or bilingual psychometrists, or even utilizing an interpreter to do a thorough interview that could help you make some predictions about bilingual language networks, even without standardized testing. As doctorate level members of a medical team, we have a certain level of power and education and access to tools that allow us to play an important role in advocacy. So to improve a patient's access to us, we can often do things like be flexible in our scheduling while being mindful of minimizing a parent's burden of taking days off of work. We can use available tools like telehealth, as well as available resources like administrative support staff that for me have been essential to aiding patients who haven't used telehealth before to setting up those tools in order to access me from their location in a rural setting, for example. So I mentioned in the beginning that advocacy is not always standing on the steps of the Capitol or calling representatives, but socially just advocacy can happen on behalf of our patients every day and through each phase of this journey to epilepsy surgery, as well as in the post-surgical monitoring that occurs. So post-surgically, I typically have a check-in, which can be a virtual consult with the family, 6 months out from surgery to screen for any new cognitive, emotional, or behavioral concerns. This is also a good touch point to follow up on recommendations from my pre-surgical evaluation to see whether any barriers have gotten in the way of the family's ability to follow through with recommendations, or whether any barriers have come up with the school in providing certain recommendations or accommodations. At that consultation, if there are new concerns or an exacerbation of pre-existing concerns, I'll typically ask the epileptologist to place a referral for a more comprehensive evaluation. And if not, I'll wait until 1 year post-surgery for that comprehensive re-eval. Okay, now I will walk y'all through a case example to hopefully demonstrate this process from phase 1 through post-operative monitoring. Okay. So this patient that we'll call Julia is a 20-year-old right-handed female with a medical history of drug-resistant epilepsy and hypothalamic hamartoma, referred for a comprehensive baseline and likely pre-surgical evaluation during her phase 1 workup on the epilepsy monitoring unit. A little bit of history on her, birth developmental history. She experienced some in utero exposure to substances. She was born full term. She received ECI. Her motor and speech language milestones were slightly delayed, and she stayed in speech therapy until the age of 5. Cognitive and adaptive history. She has a long-standing history of attention dysregulation, previously diagnosed ADHD, and she's living in an apartment on her parents' street. She's able to navigate many aspects of her daily routines on her own, but does benefit from regular check-in and support from her parents. Educational, occupational factors. So she attained her GED. She has a history of 504 supports, though she was ultimately homeschooled due to what her mom described as auditory comprehension issues and inadequate accommodations related to that. She has worked some part-time jobs, but has been let go a couple of times due to making multiple mistakes that seem to usually be due to inattention or forgetfulness or working memory difficulties. Social, mood, and behavioral. She has really good social supports through her partner, her family, and her friends. She does have a history of severe anxiety and depression with therapeutic supports and good adherence to treatment. And important to know that she also has a history of self-harm and suicidal ideation. So in phase 1, a little bit more about her medical history. She had seizure onset at 12 years of age. And she's had 3 different seizure semiologies, semiologies being the signs and symptoms of the seizure. So she's had gelastic seizures related to the hypothalamic hamartoma, in which she maintains awareness. She has bilateral arm stiffening, head deviation to the left, and she smiles and laughs. Type number 2, focal onset impaired awareness, tingling in her stomach that rises to her chest, behavioral arrest, lip smacking, and head turning towards the left, and then generalized tonic-clonic, which occurred only once in the context of a medication change. So some pieces of the puzzle of phase 1 workup, during her EMU stay, VEEG, video EEG, was abnormal due to occasional left temporal discharges, occasional bilateral synchrony, independent right temporal discharges, and other generalized discharges. MRI revealed that hypothalamic hamartoma posterior to the mammillary bodies, and MEG indicated left hemisphere dominance for receptive language, normal anatomic organization of the primary sensory cortex, and ictal discharges localized to the mesial temporal lobe. Okay, so here's a quick sample of some of her data in my write-up, hitting some of those key points I mentioned earlier. I did believe these results to be valid. There was some variability amongst subtests in her perceptual reasoning, but Julia's verbal comprehension was significantly lower than her visually based skills. Further evidence for lateralization was noted in her fine motor speed and dexterity on the groove pegboard, where her dominant right hand performance was in the below average range, and her non-dominant left hand performance was in the average, nearly high average range. Behavioral observations were really important contextualizing factors here as well. So even beyond this 4th percentile verbal comprehension performance, Julia took a lot longer to process questions or instructions that were asked verbally. She would appropriately indicate that she was thinking or working on an answer, but there was a significant response latency before she initiated verbal answers. She also had significant word finding difficulties, and her Boston naming score was in the 1st percentile. So overall, I concluded that her profile was suggestive of difficulties lateralized to the dominant, which was likely the left hemisphere. I'm abbreviating the findings for sake of time, but some of the recommendations that particularly focused on advocating for Julia's current needs, her ability to consent to treatment, her ability to voice understanding of potential risks, and protecting her from a mood standpoint as well, were the following. So providers are encouraged to take into account her difficulties with language comprehension when providing her with psychoeducation or important information about her health and medical decision-making. She would benefit from routinely checking in regarding her understanding, asking her to summarize what she understood about given instructions. Written checklists, handouts, summarizing information could supplement her understanding. And whenever possible, additional time should be given in the context of an appointment to allow her to ask questions. Should Julia's neurology or neurosurgery team decide she is a candidate for a surgical intervention, careful mapping of her expressive and receptive language was strongly recommended. And as a patient with significant history of mood dysregulation, depression, anxiety, and self-harm behaviors, Julia is at risk of an exacerbation of mood symptoms following neurosurgical intervention. So as such, ongoing evidence-based therapy like CBT or DBT and careful monitoring were recommended. So Julia ultimately underwent laser ablation of her hypothalamic hamartoma. Since then, her gelastic seizures have completely resolved, but her focal seizures have persisted. So at that 6-month follow-up with neuropsychology, Julia talked about concerns for worsening memory. She was utilizing some good compensatory strategies, making lists, writing notes to herself, and some of the difficulties with forgetfulness seem to be an exacerbation of premorbid attention dysregulation. Because of the persistence of those focal seizures, Julia is now being considered for further neurosurgical intervention targeting the left temporal lobe. So we're kind of back to phase 1.5. We did fMRI with her, and findings indicated left-sided activation, or the summary here, left dominant language on word and verb generation, bilateral activation near Heschel's gyrus of the auditory decision task. We also did a WADA with her. Briefly, the results indicated left hemisphere dominance for speech, concordant with neuropsychological workup, verbal memory greater on the left than the right, and bilateral visual memory with right side being slightly greater than the left. So because of mine and the team's concerns for risk with further ablation or resection in the left temporal lobe, the team is pursuing phase 2 workup through SEEG, where we'll do some more targeted language and memory mapping. And neurosurgery will be more likely to suggest a neuromodulatory device rather than ablation or resection because of that risk. So other areas of advocacy for this patient include flexibility in coordination and scheduling. They come from very far, and so as much as possible, I try to help out by looking ahead at appointments and offering slots for reevaluation. At times, the family will be traveling to Dell for appointments with other providers anyway. So in summary, neurosurgical interventions can potentially cure patients of their epilepsy or could provide substantially better quality of life with reduced seizure burden or elimination of the most dangerous seizures. The work up to neurosurgery is rightfully an intensive one, and epilepsy teams use all tools and resources available to try to give patients the best outcome related to seizure control while maintaining as much function as possible. The neuropsychologist's understanding of brain behavior relationships and their ability to evolve over time is critical to evaluating risks, making sure patients and the families understand what they're consenting to, and advocating for patients along the way. So being a socially responsible neuropsychologist means engaging in socially just advocacy, evaluating barriers to care, and addressing health disparities in an ongoing and active way. Okay.
Thank you, Dr. Costello. That was a phenomenal lecture and so informative. And just hearing about the different areas that neuropsychology plays a role in is just incredible. And I'm so happy that you touched on, or you really gave great information about all the ways that we can advocate and use our unique skill set in multiple ways, and just, not only beyond the numbers, as you said. We do have some nice questions with the remaining time that we have. Let's see. So question number 1, do you use formal performance validity tests? And if so, which ones?
Yes, I do. Depending on the patient, I'll look at both standalone and embedded performance validity. So usually using either the TOM or the MSVT. And then looking at embedded measures like digit span. I see a lot of adolescent and young adult patients. So like on the CBLT-3, looking at forced choice as well.
Very nice. I like that you're using both the standalone and embedded. I'm sure that helps, especially when they're all both in line. Here's another kind of procedural question for you. Are the post-op consultation / monitoring typically covered by insurance? And do you get prior authorization for these sessions?
Good question. So yes, they're typically covered by insurance. We usually bill a 96116. So at that time, it's usually been long enough since the last time we saw them to be able to bill that again. I don't see a lot of what goes on behind the scenes in terms of pre-auth because I have wonderful administrative support that helps with that. But I haven't had an issue or anything bounce back to me that I'm aware of.
Awesome. That's great. Another question is, what are some questions you ask to gauge which is the dominant language and whether you need to test in both languages?
So we use a screener in clinic that goes out, before the patient is scheduled. So I get some good kind of baseline information about what languages are used in the home, particularly what languages was the patient exposed to or immersed in between the ages of 0 and 3. So thinking about that really early exposure, what language were they using when they started to say their first words and speak in phrases. We get a little bit of information about educational experiences. So did they, and I'm mostly focused on, English and Spanish. So did they first start to read, first start to write in English or Spanish? Currently, are all of their classes, what's kind of the breakdown if they're in a bilingual classroom, or are they or have they ever received any supports like English language learner supports or English as a second language supports? And then we do also, even before they come in, get a sense of what language they tend to use, like with siblings, with friends, in their therapies, what language do they use? And ask, even though it's not always, as a standalone, it wouldn't be a good question or a good age, but we do ask parents what they think the child's preferred language is. And then the questions that I ask on interview are really always evolving and kind of hearing, what I think HNS is that consult group is a really good resource for that. Like how are we gauging what patients use the most and what they've used the most recently in their day-to-day? Like if you need to Google something, what language do you Google it in, or what phone settings in, those kinds of things. And so I won't necessarily always do the entire battery in each language. It can sometimes be targeted, really depending on, for epilepsy, is eloquent cortex involved? And I want to get kind of the functional maximum of each language. So I might be looking at expressive and receptive language in both. If whichever language appears to be the dominant one, I'm most likely to do IQ in that language. But in general, I do tend to do block testing with those patients. So I'll kind of reserve one language more so for the morning or the beginning portion of the day, and then have some transition time and then we'll do the other language in the afternoon so that we're not, shifting back and forth the whole day.
That's incredible. And I really enjoy hearing about the depth that you go into when you're trying to assess language development. And that speaks to what you were saying in the beginning of your lecture in terms of the expertise that you're providing and your understanding of neurodevelopment and language organization. So it's really nice to hear how you are assessing for that on a practical and functional level for these patients. And then you can advocate for them, like you said, if they do have, heritage language. Thank you so much for sharing that. Another question we have is, what are some challenges that you have experienced when testing on the EMU?
One is probably just the physical burden of plugging tests back and forth. We do have a decent set of tests over on the EMU, but it's a little bit of a hike from where our clinic is. I think that our EMU staff and faculty are really pretty respectful of the day that we're doing the neuropsych eval, but I've definitely been in other institutions where there's a lot, even just in the hospital setting or inpatient setting in general, where there's a lot more disruptions, people kind of coming in and out of the room. But even if providers aren't coming in and out of the room throughout the day, the patient is, potentially exhausted or coming off of medication. They're not in the most comfortable environment. They're hooked up to EEG. There are things beeping, lots of just kind of different distractors as compared to outpatient clinic, where we try to control as many of those variables as we can.
Yeah, that can definitely make it challenging. When you talk about that, what would happen if your patient were to have a seizure during your EMU testing session?
So on the EMU, they're being continuously monitored with that video EEG. And so there are techs watching that EEG all the time. If I were to see something that looked like the onset of a seizure that was concerning for seizure, there's always a button right by the bed that we press that kind of stamps the EEG at the time that symptoms, and then also alerts staff to come and attend to the patient. So other than that, and making sure that if I'm the only one in the room, the patient is safe where they are and they're not falling off of a chair or something, really getting out of the way, getting by, recognizing that there are cameras monitoring overhead, and I want them to be able to not see like the WISC materials, but see the patient and, the semiology of the seizures. Those are the main things.
That's great to know that there's that button there. And you had mentioned in your answer, one question prior, an H&S resource. Can you speak a little bit? We love hearing about resources. It's always good for us to know, as well as our listeners and from around the world.
Yeah, so H&S has a really robust CE program. And then we also have more recently kind of a consult group that happens monthly that's called Knowledge to Skills. And so it's typically to an hour and a half a month, and we alternate peds folks that are hosting it, peds adult. And we've got providers that provide bilingual care providers. It's usually hosted by a couple of kind of experts in the field. And then people who of all different levels of experience with bilingual testing or with Spanish-speaking patients will come to those consult groups and kind of ask questions, sometimes present cases, ask for feedback, ask about tests that they should buy, how to interpret findings. So I think it's been a really great resource for members.
Thank you so much. We'll definitely make sure that our listeners here, they go to the Hispanic Neuropsychology Society's website so that they're able to check those out. I know we are almost at time. We have a quick question I want to make sure, let's see, we get to, got a lot coming in. This is a fantastic topic. So one of our listeners is saying they really enjoyed the presentation. And in your experience, what are the mental health risks of undergoing neurosurgery for treatment of epilepsy? Is there a unique risk for onset of mental illness, or rather a worsening of existing symptoms?
So it could be either. It could be that there are new symptoms of, depression or new suicidal ideation following surgical intervention, certainly depending on, the location of the intervention and the type of the intervention. But definitely patients who have pre-existing mood conditions or concerns are at risk for a worsening. And so, like I said, obviously as neuropsychologists, that's something that we ask a lot about, and that we tend to learn a lot more about in the context of a given patient and their families compared to the other medical providers. And so I think that that is a really important point of advocacy is adding that emotional piece to the puzzle and not just focusing on the cognitive.
Yeah, I think that's great. And I know in your case with your the case example, Julia, you had mentioned as part of your impressions that she needed to be monitored for the potential exacerbation because she had a history, I think you said, of significant anxiety and depression as well. So just mentioning that to the team so they are aware. And I'm sure part of that is, getting those resources up and running or reestablished as well. So that's a great way that we can advocate for our patients as neuropsychologists and another part of our role. So thank you.
Yeah, absolutely. And I think it's really important to have kind of open and frank conversations with patients and families about those things as well. And kind of speaking to or psychoeducating around the ideal setup of getting established with a provider prior to the surgical intervention, right? Establishing that relationship and that safety net, and being in that routine already. Developing some of those coping skills, before surgery would be ideal.
That's fantastic. Thank you. Well, again, thank you so much for being here and sharing your expertise. This was a phenomenal presentation, and this will be uploaded by the end of the week on our website as well as on YouTube. And for those of you who are interested in coming to another lecture next week, we have a topic on transplant neuropsychology. But again, thank you, Dr. Costello, and I hope you have a great rest of your day and good week, everyone.
So much. Thank you for the attention and the good questions.